The last topic we're going to talk about with the gastrointestinal system is our colorectal cancer. For our assessment phase, the patho of this is an abnormal tissue growth, which really applies to all different cancers. This one is occurring in the colon or the rectum, so it's invading into the gastrointestinal system. Advanced versions or advanced forms of any type of cancer can invade into surrounding tissues and structures, which we start to then get concerned about metastasis, spreading to other organ systems completely. The reason patients are susceptible to colorectal cancer falls into two categories: our modifiable categories and our non-modifiable categories. Non-modifiable means it's like genetics. It's things that we just can't change in a patient, or they're not able to change in themselves. So there is a higher prevalence in men of colorectal cancer, and age, advanced age, is also a big non-modifiable variable for development of colorectal cancer. That's why we always do the colonoscopy screenings for people 50 years or older. So we do start to anticipate these high rates of colon cancer with advanced age and screen for it. Family history of cancer is always a concern for people, and also a present history of irritable bowel disease or inflammatory bowel disease. So any of our Crohn's disease or ulcerative colitis do place patients at higher risk for developing colorectal cancer later in life. Modifiable things, obesity is one. Also, nursing school, so smoking and alcohol use, don't do it because it's going to cause all the problems. And then high red meat diet is also associated with higher rates of colorectal cancer. And when we look at the whole colon here, we can identify some areas that are a little bit more at risk than others. So the ascending colon, sigmoid colon, and the rectum are kind of our top three areas of the colon that tend to develop tumors a little bit more than others, with our descending colon being kind of the least likely area in the body where colorectal cancers develop. So symptoms also vary based on where in the colon the tumor is invading. If we see left-sided tumors on patients, we're talking about the descending and sigmoid colon, we're going to see more bleeding. So like GI bleeds, like lower GI bleeds, so blood on the stool. Constipation or diarrhea, so alterations in their bowel patterns. That ribbon-like stool, so it's going to be very narrow at the end of the colon, where the stool kind of takes its final shape before defecation. It's going to be narrow because there's a tumor invading into the colon, changing the shape. Also, there's going to be a sensation that they always have to have a bowel movement. There's going to be a sense of fullness in the rectum or in the colon that won't go away, that's the presence of the tumor, unfortunately. For our right-sided colorectal cancer, so now we're talking about kind of the ascending colon into parts of the transverse colon. Usually this is going to be more asymptomatic for patients. Part of the reason here is when stool enters into the ascending colon, it's still pretty liquid. So we're not going to see any of the constipation or diarrhea because it's already liquid, and absorption will still take place throughout the rest of the colon. There's going to be some vague discomfort that patients are going to feel, maybe some cramping or colicky pain, kind of some of that transient abdominal kind of discomfort. And also occult bleeding. Occult bleeding meaning there's going to be blood in the stool. So not streaked on the outside of stool, but mixed into the fecal matter because all the feces is still liquid at this phase of the gastrointestinal cycle. So those are kind of the differences in how we're going to look at these things as to where the tumor is going to be and how we might identify that in our patient. So for the medical diagnosis, the physicians are going to first start with their screening. So is there a family history? And then what's their physical exam like? Is there a palpable tumor on abdominal assessment? Do they have bleeding with their stool? Is it on the outside of the stool or in the stool? In order to do that, to check for blood, we're going to do what's called a guaiac on the stool. And that's a test that can either be done at the bedside or in the lab, and we're going to test the stool material for the presence of blood. The gold standard medical test to determine if a patient has colorectal cancer is a colonoscopy. So that's always going to be definitive. So they're going to insert a camera into the colon, look for that invading tumor, and actually take a biopsy while they're doing their colonoscopy so that they can diagnose and stage the type of invading tumor that is present in the bowel. So stage 0 is kind of, there isn't really much cancer at all. Stage 4 being our most advanced, where we have a highly invasive tumor, but we also have metastasis to other organs that are not part of the GI system. So for our nursing diagnoses, because this is a cancer thing, we really have 2 different categories of nursing diagnoses that apply to this type of patient. The first is our physical stuff. So we may have things like altered bowel patterns, constipation, dehydration associated with diarrhea, addressing the physical symptoms that patients may have, sometimes pain, sometimes not. The other big categories are psychosocial stuff. So anytime you start throwing around the C word with patients, there's a risk of fear, anxiety, helplessness, emotional lability, meaning they're unpredictable in how they're going to respond, knowledge deficits about what are the next steps in their treatment, what options are available, those sorts of things. So we really have to focus kind of more holistically whenever we're dealing with a cancer to focus on the physiological and the psychosocial for our patients. The medical plan with colorectal cancer is first and foremost decrease the growth of the tumor. It's an abnormal cellular growth, so they want to stop that abnormal cellular growth. And medically, the way we do that is radiation and chemotherapy. Radiation being a focused beam of energy that should kill tissue in a very specific place in the body. And in this case, they'd be targeting that area of abnormal tissue growth that is the tumor. Chemotherapy is a little bit more broad acting, where it's going to attack rapidly dividing cells is kind of the main target of chemotherapy, which tumor cells are. They're dividing and replicating much more quickly than the surrounding tissues or healthy tissue. So that's what our chemotherapies tend to target. Patients will usually also have surgical management as part of the kind of menu of options to treat their colorectal cancer. 2 things are going to happen. One is a colon resection. So the area that has the tumor is going to be resected. And they're going to resect out the colon until they get what's called a clean margin, meaning that the last incision doesn't have any presence of tumor cells. So that means that if the cancer is here, they're going to resect a tissue or a segment of bowel that is well outside of where the cancerous cells are to make sure that they've removed all of that disease presence. Depending on the severity of the bowel resection or the need to have bowel rest afterwards, there may need to be a colostomy. And this could be either a temporary or a permanent colostomy, depending on the kind of how extensive the amount of cancer and the location of the cancer in their bowel really is. And do keep in mind also our double barrel ostomy is our most temporary. All of the other types of ostomies are more long-term. So that's what we need to look out for. For our nursing plan, we need to support our patients through this entire medical treatment. So we're going to be focusing at every different stage of the procedure that they're going to get for the treatment and removal of this cancer in their body, and really looking out for their well-being. So while they're going through radiation therapy, we need to pay attention to the skin, like right over where their cancer is, because the radiation beam that they're using to treat that cancer can actually cause very, very severe burns to the skin, almost like a very severe sunburn. So we do need to treat our patient and protect them from that. Chemotherapy, we need to help support them through that. It can be, depending on the type of chemotherapy used for different types of cancers, it can be really mild, or it can be very, very severe in the amount of side effects that patients experience as a result of that treatment. So symptom support is a big one, like nausea, anorexia, those sorts of symptoms that are common. We do want to try and support patients through those, either pharmacologically or with other types of counseling. And then for ostomies, first we need to prepare them for the surgery so they know what to expect when they come out of surgery. Here's a post-op operative patient or ostomy patient. This patient looks like they're still in the OR, like somebody's wearing a sterile glove, sterile dressing, all that kind of stuff. But they need to be ready to see this when they come out of the OR. This is the stoma that's been pulled through the skin. It's that portion of bowel. And they're going to be having stool drain into this collection bag for a period of time, dependent on whether it's going to be a short-term or a long-term ostomy. So new ostomy patients need the teaching that goes along with this type of device. How to empty it, how to clean it, how to change this dressing, those sorts of things. Most nurses are pretty good at ostomies, and they get better over time, but our real resource in the inpatient environment and outpatient is our enterostomal therapist, or more commonly known as the wound ostomy care nurse. So our wound care nurses are trained in ostomy care as well, and they can really be helpful when we start talking about how to teach patients how to manage these things and get them ready to transition out of a hospital into being able to self-care with this type of medical device. So for implementation, pre-operative, the things we want to push for our patients and really encourage: high-calorie diets, probiotics, calories, and low residue diet. So things that are easily digestible but the highest caloric intake that they can get. Knowing that after their surgery, they're going to have an increased caloric need for wound healing. And because of some of the other treatments like radiation and chemo, they may have a decreased appetite. So the more calories we can get into them early on, the better. Decreased bacteria in the bowel because of the bowel prep. So probiotics are really important. Bowel prep, it's usually done by a medication called Go Lightly, which is like the worst name for that medication because it really just makes you like shit your brains out. It's kind of crazy. But because of that high volume of diarrhea, it's going to start flushing the natural gut biome with it. So they are going to have that decreased level of healthy bacteria in their gut. Also, their level of anxiety. These patients were just diagnosed with cancer. Odds are they're going to be going for surgery related to that cancer. Anxiety and fear are definitely going to be two big things that we need to pay attention to for these patients. Post-operatively, we need to look for the return of peristalsis. And that really applies to every patient post-operative, but especially patients who have had any type of procedure on their actual bowels themselves. So first thing, passing gas. Second, return of bowel sounds to all four quadrants. And then we can start to anticipate that the patient's going to produce stool shortly thereafter. Gastric suctioning. So this is via NG tube, depending on where the cancer in the bowel really was and whether or not that needs to continue. So if they have an NG tube in place, we need to make sure that tube stays patent, meaning that the suction isn't blocked, that we're actively removing gastric contents. And then once the patient starts to have a return of normal bowel sounds and activity, we want to take that tube out and start promoting PO intake for our patients. And then the stoma. We need to pay attention to that stoma, make sure that it stays healthy, and there's no signs and symptoms of surgical complications. Things like bleeding from around the incision site where the stoma has been pulled through the skin, and signs of necrosis for that stoma tissue. So a bluish color indicating that it's cyanotic and being constricted, or like a black color, meaning that there's tissue necrosis. And then, of course, like with any surgery, monitor the incision, any drains, any of those other kind of the gear they come out of surgery with to make sure they're not developing any signs and symptoms of infection. So our evaluation for colorectal cancer, really is focused on the completion of their acute treatment. It's what is the treatment that's been prescribed to eliminate their tumor to the appropriate amount that they're willing to receive that treatment. So do they want to have surgery, radiation, and chemo, or are they picking and choosing different aspects of that, and how can they complete that? Prepare them for surgical management and surgical recovery. Prepare them for ostomy management and ostomy self-care as an outpatient. And then ongoing therapy preparation, because oftentimes when patients have colorectal cancer, the surgery will take place in the hospital in an acute care environment, but the radiation and the chemo, while they may be started while the patient is in the hospital, they're going to continue those therapies as outpatients. So we do want to prepare them for the duration of therapy that they're going to be in for in order to fully kind of rid themselves of the cancerous material that's in their colon. That's it for colorectal cancer.